Hello everybody. Today I will be discussing about the management of organophosphorus compound, and after that we will see some clinical features presented by the patient, and in the last we will see the mechanism of action of this poison. So before starting how to manage the patients with this poison, let me just introduce some points about this. So what is the organophosphorus compound? uh, this is mainly used in agriculture and household as an insecticides, and the incidence of this poisoning is more often it is accidental. After that it will uh, sometimes it can be suicidal and homicidal very uh, list. Okay, so uh, so this is the organophosphorus compound, and it is the insecticides, and this is derived from uh, the phosphoric acid, and as I have already told you that this is the common component of agricultural and household insecticides, and mode of poisoning is most frequently it is accidental. uh, if a child ingests this, and sometimes it can be suicidal, and homicidal is very rare. So examples of these organophosphorus compounds are uh, difluores, ecothiophosphate, parathione, malathione, diazinon, stabum, sarin, salmon, etc. So we will discuss the management in two parts. First, supportive management, and then the specific management. So what are the supportive managements to those patients? So termination of further exposure by moving the patient to fresh air, washing skin and mucous membrane with water, or even doing gastric lavage if necessary. Maintaining patent airway by tracheostomy and nasopharyngeal tube, O2 administration, especially in the presence of cyanosis. Gastric lavage if poison ingested with 1 is to 50,000 potassium permanganate plus retaining activated charcoal in the stomach. Supportive measures such as maintaining blood pressure, hydration, and convulsions treated with oxygenation, benzodiazepine, and antitone. Pulmonary edema and bronchospasm treated with oxygen intubation, atropine, and positive pressure ventilation. So now moving to the specific treatment, atropine. Atropine is highly effective in counteracting muscarinic symptoms produced by organophosphorus compounds. Also antagonizes central effects at higher doses. However, it does not reverse peripheral muscular paralysis. Hence, atropine is used in the treatment of organophosphorus poisoning. Dose 2 to 4 milligram intravenous as a test dose, followed by double the dose every 5 to 10 minutes until pupils dilate. Should be continued till tracheobronchial secretions stops and bronchial tree is cleared of any secretions. After sufficient atropinization, dose is adjusted to maintain atropinization for 24 hours. Cholinesterase reactivators. DAM, diacetyl monoxide, 2-pyridine aldozyme methiodite, 2-PAM, or pralidozyme iodide. Pralidozyme chloride, 2-PAM chloride, used to these cholinesterase reactivators, DAM, 2-PAM, or 2-PAM chloride, are used to restore neuromuscular transmission in the OP poisoning. Use is secondary to atropine. When more more reactive hydroxy groups in form of oximes are provided, phosphorylated cholinesterase, which reacts very slowly or not at all with water, reactivation occurs more than 1,000,000 times faster. Act by competing for phosphate moiety of organophosphorus compound and release it from cholinesterase enzyme. Action is marked at nicotinic sites, improving muscles strength within 40 to 50 minutes. Also abolish muscarinic and CNS symptoms. So what are the doses for these choline esterase reactivators. 1 to 2 gram intravenous as a 5% solution given over 5 minutes or in 150 milliliters of saline infusion over 30 minutes. Dose can be repeated in 1 hour if muscle weakness and fasciculations are not relieved. Dose is repeated at 6 to 12 hours intervals for 24 to 48 hours to ensure distribution to all affected sites. Otherwise, 2.5% solution can be given as continuous infusion of 0.5 gram per hour. If signs and symptoms persist, dose is continued till symptoms subside. So this was how you will manage the patient, but before starting any treatment you need that how will you know that this is the case of organophosphorus poisoning. So by asking the patient himself, or if a patient is not able to say that, then you can ask the relatives. They will tell you that if it is child, then they will tell you that he has ingested some insecticides or like this. Or in case of suicidal attempt or homicidal attempt, the relative who will come, who will bring the patient to you, will tell about this. Otherwise, you can also see the patient, examine the patient, and there are some clinical features. Based upon the clinical features presented by the patient, you can reach at the conclusion that this is the case of organophosphorus poisoning, so that you will start the supportive and specific treatment to that patient. So what are those clinical features presented by that patient? So central nervous system stimulation followed by depression. So restlessness, emotional lability, headache, tremors, drowsiness, confusion, slurred speech, ataxia, generalized weakness, coma, convulsions, depression of respiratory and cardiovascular center. So these are the central nervous clinical features, and some muscarinic effect you will observe. Increased postganglionic parasympathetic activity affects pupils, bronchial muscles, salivary and sweat glands, urinary bladder, cardiac sinoatrial node, and bronchial tree, bronchoconstriction, cyanosis. Increased cyanosis is the bluish discoloration of your nail beds and skins and some below your eyes, and so you can observe that. So okay, so yeah, respiratory, bronchial tree, bronchoconstriction, cyanosis, increased bronchial secretions, dyspnea, pulmonary edema, gastrointestinal tract, uh, anorexia, nausea, vomiting, cramps, diarrhea, fecal incontinence, tenesmus, sweat gland, increased sweating, salivary glands, increased salivation, increased in lacrimal glands, increased lacrimation, uh, in cardiovascular system and the sinoatrial node, bradycardia, hypotension in eyes, meiosis, blood vision in bladder, urinary incontinence in urinary bladder. So main muscarinic effects are salivation, lacrimation, urination, defecation, GI, gastrointestinal disorders, and emesis. Some nicotine stimulation, paralysis of preganglionic and somatic motor nerves, twitching of eyelids, tongue and facial muscles, neuromuscular block and paralysis, of striated muscles, muscular fasciculation, cramps, weakness, areflexia, muscle paralysis, sympathetic ganglia, hypertension, tachycardia, pallor, and mydriasis. So to summarize the clinical features of due to nicotinic stimulation, they are mydriasis or muscle cramps, tachycardia, weakness, twitching, hypertension or hyperglycemia, fasciculation, etc. So what is the mode of action? So organophosphorus compounds are anti-cholinesterases or cholinesterase inhibitors, powerful inhibitors of carboxylic esterase enzyme, including acetylcholinesterase, followed by bind firmly to esterase enzyme at myoneural junction and synapses of ganglion. Inactivation of enzyme by phosphorylation, inhibition of acetylcholinesterase in the whole body. That's why I told you In the specific treatment, uh, mm, while giving the cholinesterase reactivators, you will have to give the continuous intravenous infusion of 0.5 gram per hour to the patient to make sure that the cholinesterase reactivator medications should reach to your patient's whole body. Okay. Because the inhibition of acetylcholinesterase occurs in the whole body by these organophosphorus compound poisoning. Then after this inhibition of acetylcholinesterase, this is followed by accumulation of acetylcholine at parasympathetic, sympathetic and somatic sites. After this, prevention of transfer of nerve impulses across synapses at autonomic ganglia and neuromuscular junction, and at last syndrome of overactivity due to unhydrolyzed acetylcholine. Okay, so this was the mechanism of action. So in this organophosphorus poisoning, we discussed about what is the organophosphorus compounds. So organophosphorus compounds are insecticides commonly used in household and agriculture. The mode of poisoning is more frequently seen. This is accidental in case of children, and this can also be suicidal in case of suicidal attempt by anyone, and the homicidal is very rare. Okay, so this was okay. So, and in while discussing about the treatment of the patient, we discussed about two modes of treatment. First is supportive treatment and then a specific treatment. In supportive treatment, we discussed about we have to maintain the ventilation, proper ventilation to that patient, either natural or by artificial mode, and to ensure the proper oxygenation to the body, and also will have to maintain the blood pressure, and patient should be hydrated to excrete the organophosphorus compounds in urine, and etc. And in a specific treatment, we discussed about the atropine. This is the first choice, and after that, because atropine, this has only central effects and not the peripheral effects. So this is the this is the first you should start in a specific treatment, atropine. Okay, we have already discussed this, and secondly and lastly, the cholinesterase inhibitors, in which we discussed that cholinesterase reactivators, because these organophosphorus compounds inhibits the cholinesterase enzymes and bond firmly to the cholinesterase, and so in that we told you that we will be giving the hydroxide hydroxyl group, uh, and it will compete with the phosphorus, and uh, yeah, and it will take about 40 to 50 minutes, uh, that muscle strength will be um, restored. And doses, we discussed 1 to 2 gram intravenous as 5% solution given over 5 minutes, and we have already discussed all these things. Or continuous infusion of 0.5 gram per hour to the body. And in the clinical presentation, we discussed some CNS effects, in which we saw restlessness, emotional liability, headache, tremors, androgynous confusions, blurred speech, ataxia, generalized weakness, coma, convulsions, depression of respiratory and cardiovascular symptoms. So we will have to maintain the blood pressure of and the proper infusion of and also we will have to maintain the respiration, because some centers are affected. Okay, and some muscarinic effects, in which respiratory, gastrointestinal, respiratory bronchoconstriction, cyanosis, and etc. And gastrointestinal tract, anorexia, nausea, vomiting, etc. will be observed. And increased sweating, increased salivation, increased lacrimation, all these things will be absorbed. Bradycardia will be absorbed, and hypotension will be there. So maintain the blood pressure to ensure the proper infusion of the blood throughout the blood, and hydration is also important. And in eyes, you will observe the meiosis and blood vision, and urinary incontinence will be observed. So the and nicotinic stimulation, muscle paralysis, cramps, weakness, etc. will be there in the striated muscles. And tongue, facial muscles, and eyelids twitching will be also observed. And the mode of action, we told you that it inhibits the acetylcholinesterase enzyme throughout the body, and it will be accumulated. And so to get more about this, in my previous in my some other previous videos, I have discussed the pharmacological effects of the drugs, in which we have discussed how some drugs can be excreted out, and some are even not excreted out. They are restored in the body, because in case of liver dysfunction, if patient is already having liver dysfunction, or any nephrologic renal disorder, so in that case these drugs will not work. So before you should know that if patient is suffering from this renal or hepatic malfunction or not. If not, then it's okay, and if suffering, then I have discussed in that video. You can refer that. Okay, thank you. Thanks for watching. Subscribe, share, and write in the comment box how is this video, and also subscribe our channel and like it, share with your friends. Okay, thank you, thanks for watching, and visit my site facebookuniversity.com, facebookuniversity.com. Thank you. You can also follow me in my Instagram, Abhishek Dilti Vishali Anande. Okay, thank you.